On to our second talk for the day. And I am very challenged, so I'm going to try to share my screen. Let's see, can you see this?
Yes.
Yes, perfect.
Yes.
Excellent. Okay, so we're going to talk about rocks in a kid's kidneys. And I'm going to start with a case. So this is a 16-year-old boy who was referred for intermittent dysuria, some vague flank pains, and microscopic hematuria. And he went to his pediatrician 2 times, 3 times. They suspected a UTI, cystitis, but they got 3 negative urine cultures. And so they finally referred the patient to nephrology saying, we don't know what's going on. Absolutely negative family history of kidney disease and completely normal physical exam. So when this patient presents to us, what is the next step? Many of these questions are, of course, directed towards the trainees in the audience. So our next step is to look at the urine very carefully. And so we spin the urine down, we look at it, and this is what we see. What we see is eumorphic red blood cells. You can see that, those little dots all around. There were no casts, so that suggested that this patient didn't have a glomerular cause of hematuria, no bacteria, so this is not a UTI, but certainly beautiful crystals. This looked like a jewelry store to us. So the next question is, what type of crystals are we looking at? And this is the way I remember oxalate crystals. The X looks like an envelope. So envelope-shaped crystals, as you can see here, here, this is typical of calcium oxalate. So for some reason, this young man has calcium oxalate crystals. And then we look at his kidneys because he's had some flank pains, and this is where the title for the talk came up, the rocks in this kid's kidney. So this is a rock, this is a rock. And what you can see is these are echo-dense stones in both kidneys. And then you see this very classic acoustic shadowing on the ultrasound. And that is typical for kidney stones. If you don't see this acoustic shadowing, then these could be either fat or blood vessels or lymph nodes or something, but not stones. So this very much suggests to us that this young man had kidney stones in both kidneys. And then we do another thing called a Doppler examination. And by Doppler, we see this so-called twinkling artifact. Very, very pretty when you see it. And that is, again, very classical. So here's the kidney stone right here. And then what it shows is this twinkling artifact. It's an artifact. But when we see this artifact along with this artifact of acoustic shadowing, that really establishes the diagnosis of kidney stones. We also do a KUB to look at what kind of stones this possibly could be. And you can see there are multiple radiopaque stones, multiple small ones in this kidney, one big one in this kidney. And that told us already that this is either calcium or cysteine or struvite, because we all know that uric acid stones cannot be seen on a plain X-ray because they're radiolucent. Just to remind us, mostly urinary oxalate crystals look like envelopes. Those are the dihydrate form, but we can also see the monohydrate form, which is dumbbell shaped, and you can see monohydrate forms, which are needle shaped. And sometimes you can see multiple forms of calcium oxalate. And it's important to determine this because, as you'll see later, the type of crystals determines how hard or how soft the kidney stone is going to be. Okay, so calcium oxalate. As I said, dihydrate, envelope shape, they can form soft kidney stones, so they're much easier to treat by lithotripsy, but the monohydrate crystals form stones that are very hard and they're much more difficult to treat by lithotripsy. So we got to think about risk factors for calcium oxalate crystal formation in this patient. And the most common risk factor today is low levels of citrate in the kidney and in the urine. And we'll come back to this concept later. It used to be hypercalciuria as the most common cause, but now in the last 5 to 10 years, it has become obvious that low citrate levels are more common than high calcium levels. And then there are some rarer causes, high oxalate levels and low urine volume. So these are the different things we look for in patients when we see calcium oxalate crystals and kidney stones. So we start with the urine calcium to creatinine ratio and the urine citrate to creatinine ratio. As you can see, both of those will vary with the age. And this you can do just on a spot urine sample. You don't need to collect a 24-hour urine. And in this patient, the calcium creatinine ratio on a spot urine was 0.18, which, as you can see, is completely within normal limits. He is 16 years old, so less than 0.2 is normal. And his spot urine citrate to creatinine ratio was also very normal. So the two commonest causes of calcium oxalate crystals came back negative in this patient on a spot urine. So then we move to the next step, which is to check the oxalate level in the urine. And what we're showing here is the different oxalate to creatinine ratios. Again, it changes with age. It's high in the infant, but beyond 6 years of age, it should be less than 0.06 on a spot urine. And his spot urine oxalate to creatinine ratio came back at 0.4, which was suspicious for hyperoxaluria. So then what's the next step? The next step is to measure 24-hour urine for risk factors of kidney stones. So we already talked about the spot urine, which showed a high oxalate level. And here, the same patient got a 24-hour urine check. Oops, sorry. And what we saw was, first of all, the creatinine in the urine was normal. And we want to see that to make sure that it was a real, true 24-hour urine. If the creatinine was low, that means that the patient did not collect the full 24-hour urine, and the results are not reliable. You can also see that the urine volume was beautiful, 2 liters. So he was drinking well, and so it was not the fact that he was not drinking and not urinating that is causing the crystals in the kidney stone. The calcium was normal, both in 24 hours as well as corrected for the weight. But what was clearly abnormal again was the urine oxalate was quite high, it was 125. And that was reflected in a supersaturation of calcium oxalate being quite high. So what we find is both by a spot urine as well as by 24-hour urine, his urine oxalate level is quite high. So what's our next step at this point? So we think about all the causes of hyperoxaluria. And really the most common cause is idiopathic. And that means I'm an idiot and I don't know what the cause is. But we also think about a high oxalate diet. So spinach, rhubarb, potatoes, nuts, chocolate, coffee, and infants who take gastrostomy tube feedings do get a lot of oxalate crystals and calcium oxalate stones because of the high oxalate content in the diet. Dietary calcium deficiency is a very important cause. In the old days, about 10 years ago, patients with kidney stones were given a calcium restricted diet. And we very soon found out that that was a big mistake because patients who were on a low calcium diet were the ones that were getting more kidney stones. And the explanation is because when you have a low calcium intake, there is not enough calcium in the gut to absorb oxalate. A lot of food contains oxalate. So when there's not enough calcium in the diet, there's a lot of free oxalate in the gut, which is then absorbed and causes hyperoxaluria. Same concept with fat malabsorption. When there's fat malabsorption, when there's excessive fatty acids in the gut, they bind calcium. And so there is less calcium available in the gut, and therefore there is more free oxalate in the gut. And this we see commonly in patients with bowel resection, many types of inflammatory bowel disease, pancreatitis, cystic fibrosis, all conditions that cause excessive fatty acids in the gut, which then bind calcium. And then there are some medications, especially excessive vitamin D, vitamin C. Vitamin C is actually directly metabolized and converted to oxalate by the liver. And so that can cause high oxalate levels. And then there are rare causes like primary hyperoxaluria, which are genetically determined. So we went through all these causes in this patient, and he was drinking well. He was not eating a high oxalate diet. His calcium was normal, and he was not ingesting a lot of vitamin C. So we were still puzzled. What is the next step? Why does he have so much oxalate in his urine? We then did the genetic testing. And the trigger for genetic testing is any oxalate in the 24-hour urine that is greater than 80 milligrams per day or greater than 100 milligrams per 1.73 meters square per day. So typically oxalate in the urine should be less than 40 milligrams a day. Patients with enteric hyperoxaluria can have in the range of 40 to 60, but above 60, I start worrying about primary hyperoxaluria, and certainly above 80, I would definitely proceed with a genetic test to rule out primary hyperoxalurias. So we did that, and indeed in this patient, we were able to confirm the diagnosis of PH1 or primary hyperoxaluria type 1. So that was the journey that this child took, and we'll come back to this patient. I want to step back for just 1 minute and talk about pediatric kidney stones in general. I want to try and convince you that the incidence of pediatric kidney stones is extremely high and is rising all over the world. And it's really associated with high morbidity and high cost, and recurrence is very common in children, as opposed to adults who might get a kidney stone and not have any problems for 5, 10 years. In children, recurrence is the usual rule rather than the exception. And the other big difference in children with kidney stones is an underlying risk factor is almost always detectable. And therefore, we should always look for an underlying risk factor in all children with kidney stones. Typically, adults with kidney stones, they get a kidney stone, it's very painful, they pass it, nobody cares about it anymore. That is the complete wrong approach in children, because they will have a metabolic abnormality in half the cases, they will have a structural abnormality in another 25% of the cases, and they will have recurrent urinary tract infections as a cause for crystals and kidney stones in 25% of the cases. So take-home message is we always have to look for either a metabolic abnormality or a structural abnormality or recurrent UTIs in children and young adults with kidney stones. So incidence. It's about 1 in 1,000 children and adolescents, 1 in 1,000. And there are many, many publications, and I've listed them down there, showing and documenting that the incidence of kidney stones is really high, 1 in 1,000. And that's in most countries. If you look at just hospitalized children, about 1 in 685 pediatric hospitalizations in the US is because of a kidney stone. So you can imagine how common this is. And we deal with it all the time. And that incidence has been increasing really at an alarming rate, 5 to 10% every year for the past 20 years. 5 to 10% increase every year for the past 20 years, and is still going up in our center, in all of US, and in fact, in most countries in the world. The incidence of kidney stones in children is just dramatically increasing, and it's become an epidemic. And the reasons are not clear. We know it is associated with increasing prevalence of obesity in all of our children and young adults. It is associated with increasing sodium intake and decreasing water intake, and perhaps with increased awareness. But the main causes are unknown, but the strong association has been demonstrated with increased prevalence of obesity, sedentary lifestyle, increasing sodium intake, and decreasing water intake. Kidney stones affect children and adolescents from all age groups, but the greatest incidence is in adolescents. Both genders are equally affected, but boys are more commonly affected in the first 10 years of life because of many of them having obstructive urinary tract malformations. And girls are more commonly affected in the second decade of life, probably because they have increased rates of UTIs. But really it's seen in all age groups and both genders. It affects children worldwide. The greatest increase in incidence is seen in certain endemic areas. For example, in Turkey, 10 to 20% of all adolescents have kidney stones. 10 to 20, 1 in 5 kids have kidney stones in Turkey. Very, very common. And many other countries have what are called as stone belts. So here in the US, we have a kidney stone belt, which is all the southern states of US. And the incidence of kidney stones there is 5 times more than the northern parts of US. And there are many possible causes for that: increasing obesity, increasing salt intake, perhaps warmer or hotter weather, which leads to more sweating and therefore more dehydration. For some reason that we completely don't understand here in the US, kidney stones are almost exclusively seen in Caucasian children, and it's very rare to see it in African-American children, and we don't know why. Something to do with the genes. Recurrence is the big problem in pediatric kidney stones. And about 3 years ago, Greg Tasian's group showed that more than 50% of children will recur within 3 years of an index stone. So the most recent data shows that more than 50% will recur within 1 year of the index stone. So think about it. If a 6-year-old gets a kidney stone, he's going to get another one in 2 years, and then another one in 1 year, then another one. By the time he becomes an adult, he's going to get about 10 kidney stones, which is terrible. Terrible for many reasons, and we'll come to it later. And obviously, the ones with metabolic or genetic or urinary tract abnormalities are the ones that get the highest incidence of recurrence. Recurrence is a problem because it causes pain. The children miss a lot of school, they miss their activities. Yes, lots of work hours lost for parents, and there are high clinical costs with kidney stones. But maybe the most important teaching point here is that kidney stones are strongly associated, causally associated with the development of chronic kidney disease. And we've had several patients with recurrent kidney stones during infancy and childhood for many reasons that then develop chronic kidney disease and even end-stage renal disease. And the proof of that is shown right here in these 3 kidney biopsies done in patients who had kidney stones. And just take a look at this. Take a look at this one here. Take the whole interstitium here. The tubules are gone. The interstitium is gone. Even the glomeruli are sclerosed. Here's another good example of where the tubular interstitium is completely fibrosed. And here's a more mild case. But so you can see changes in the glomerulus, in the tubules, in the interstitium. So what happens is that when these crystals get deposited in the tubules, there is massive damage to the tubules. They leak into the interstitium. They cause an inflammatory response in the interstitium. There is interstitial fibrosis, tubular atrophy, and secondary glomerular sclerosis. This doesn't look like a kidney to me. And this is just a patient who had kidney stones and no other primary kidney disease. So take-home message, kidney stones lead to chronic kidney disease. Composition. The frequency of different kidney stones in children is mostly either calcium oxalate or calcium phosphate or mixed calcium oxalate, calcium phosphate. A lot of stones start as calcium phosphate in what is called as Randall's plaques, and then calcium oxalate gets deposited on top of that. There are rare causes like magnesium ammonium phosphate, also called struvite stones, common in patients with recurrent infections. And then there are rarer genetic causes like cysteine and uric acid. An underlying risk factor, as I said before, is identified in 90% of all cases of pediatric kidney stones, either urinary metabolic abnormalities or urinary tract structural abnormality, or recurrent UTIs with or without any of the above two. So it really behooves us to very carefully look for these. So what are the most common metabolic risk factors? We talked about hypercalciuria, but now hypocitraturia has now become the most common cause. In the case that we presented, it was hyperoxaluria, and there's low urine volume, which exacerbates crystal formation and kidney stones, no matter what the underlying metabolic factor is. And like I said, recent trends have shown this dramatic increase in the detection of hypocitraturia in patients with kidney stones, and we really don't know why. So how do these kids present to us? Pain is usually the most common reason they present to us, and it can be either flank pain, or what's classically called as renal colic, but increasing number of kids are presenting with abdominal pain, upper abdominal pain, and they get dismissed as gastritis, gastroenteritis. They get worked up for things like gallbladder disease and pancreatic disease, but all the time, all they have is kidney stones. So kidney stones are an important common cause of abdominal pain, especially persistent recurrent abdominal pain. They can have gross hematuria with or without abdominal pain. Patients can present just with gross hematuria. Sometimes they will present with no gross hematuria, no pain, but with dysuria, frequency, and urgency. All symptoms that we think about of UTI or cystitis, and we do culture after culture after culture, and everything is negative, but turns out that the crystals in the urine cause irritation of the bladder and the external genitalia, and frequently that is the presenting symptom of crystals in the urine as well as kidney stones. Nausea, vomiting will be present in patients with obstructing stones, and then about 20% of pediatric kidney stones are detected incidentally, which means that patients will have abdominal pain or maybe have a sports injury or abdominal trauma, get some imaging done, and boom, the kidney stones are found. They may be asymptomatic, but they're found incidentally. How do we evaluate for these risk factors? Like I said, the problem here is recurrence. And so we should, after an acute episode, all children should be fully evaluated for risk factors that promote kidney stone formation. If you're lucky enough to get a kidney stone that is retrieved, then we can send that for a direct analysis and you can come to the bottom of what is causing the kidney stone. 99% of the time, we don't have a retrieved kidney stone, and there we depend on the comprehensive metabolic evaluation of blood and urine. So let's come back to our case. So this patient had a 24-hour urine done, like I said, and had a high oxalate level and had a genetic test confirming the diagnosis of primary hyperoxaluria type 1. And so for the next 10 minutes, we're going to talk about this rarer cause of kidney stones on the one extreme of the spectrum of kidney stones, because this is a very important cause to detect as early as possible, because the overwhelming majority of patients, if they're not treated adequately, will progress to end-stage renal disease, and they have a terrible, horrible quality of life. Let me get to these. So primary hyperoxalurias, there are 3 types, maybe 4 types, but genetically we know that there are 3 types. And mutations in one of the 3 genes whose products are required for normal glyoxylate metabolism in the liver is the cause of primary hyperoxaluria. So it is a liver disease, it's not a kidney disease. The liver is not able to normally metabolize glyoxylate because of a single gene defect. The 2,000 other genes in the liver are absolutely fine, but that one gene defect leads to overproduction of oxalate. And that oxalate gets deposited in various organs, including the kidney, but also other organs. So there are 3 types, like I said, pH 1, 2, and 3. Type 1, which is the most common, 80% of cases, is due to mutations in the hepatic peroxisomal alanine glyoxylate aminotransferase enzyme. So it is AGT, the enzyme in the hepatic peroxisome that is responsible for conversion of glyoxylate to benign metabolites. If that enzyme is absent, you will get accumulation of oxalate. pH 2, which is less common, is due to mutations in a cytosolic enzyme, GRHPR. And pH 3 is due to mutations in a mitochondrial enzyme. And I'll show you a little figure that puts all this into perspective. So you can have mutations in the liver cell in the peroxisome or in the cytosol or in the mitochondria. And this picture sort of summarizes that. In purple is pH 1, which is the peroxisome here. And the problem here is AGT, which is responsible for converting glyoxylate to glycine and other important metabolites. If that is absent, glyoxylate then gets converted to oxalate because of the presence of an enzyme called glycolate oxidase. So remember GO, we'll come back to this later. So in pH 1, you get excessive oxalate production, which then escapes into the cytosol. And then in the cytosol, both oxalate and glyoxylate are converted to oxalate by a common enzyme, LDH, lactate dehydrogenase, we all know it. And so when there is a problem with this enzyme that should be converting glyoxylate to glycolate in the cytosol, we get excessive production of oxalate. And then in the mitochondria, the HOGA gene is responsible for conversion to glycolate, and excessive production of that leads to oxalate production. So in the purple is the most common, peroxisomal AGT deficiency. The second most common is a problem in the cytosol. One enzyme, one mutation can cause this havoc. What's happening? Excessive oxalate is excreted by the kidneys, and that leads to calcium oxalate supersaturation, as in our patient. It causes both nephrocalcinosis as well as nephrolithiasis. And I will show you pictures that differentiate the two. Nephrocalcinosis is calcium deposition in the kidney. Nephrolithiasis is actual kidney stones. It can cause obstruction and progressive renal damage, as you saw in the kidney biopsy that I showed you. Crystal deposition in the tubule cells and interstitium leads to inflammation, fibrosis, progressive renal damage. And when the GFR falls below 40, that's when the real trouble starts, because then plasma oxalate begins to rise when the GFR falls below 40. And the kidney cannot excrete the high plasma oxalate load anymore. Once plasma oxalate starts to rise, you get widespread oxalate deposition in the microvasculature of all organs. And the ones that are most affected are the eyes, the skin, the bones, the myocardium, and CNS. And that's what causes all the extra renal manifestations of primary hyperoxaluria that pediatric nephrologists hate to see. So there are three forms of presentation of primary hyperoxaluria. There's an infantile form when they present as infants. There's a childhood form. They present during childhood, and there's a young adult form. And they're approximately 1/3 each. So the infantile form, they present with nephrocalcinosis, hematuria. More commonly, they present with failure to thrive and progression. By the time we detect this, most of these kids have at least CKD stage 3, some have CKD 4 and 5, and have already progressed to end-stage renal disease. And by the time we make the diagnosis, they already have not only nephrocalcinosis, but they also have systemic oxalosis. The infantile form is the most explosive form. The childhood form, they get kidney stones over and over and over again. They can also have hematuria, and they progress to end-stage renal disease a little slowly, but over a few years, most of them also progress. And then there's the young adult and adult form. They get occasional kidney stones, but they usually do not progress to end-stage renal disease. So when they present as young adults and adults, even patients with primary hyperoxaluria type 1 can be managed by just managing their kidney stones without having to worry about progression to end-stage renal disease. And then nowadays, we are detecting more and more by family screening. So when we see a child with PH1 by genetic testing, we will screen both parents and we will screen the other siblings to look for PH1. But like I said, most commonly, delay in diagnosis is our biggest problem. Many cases already have CKD prior to the definitive diagnosis. And this is what nephrocalcinosis looks like. On the right-hand side, we're seeing what is called as cortical nephrocalcinosis. You can see that the cortex is looking like chalk, more intense than even the liver. And that we see in severe ischemic injury, like hemolytic uremic syndrome and severe ischemia reperfusion injury. Today, we're talking about this. We're talking about medullary nephrocalcinosis, where the medullary region is fully obliterated with this chalky substance. And we typically see this in these conditions: hypercalciuria, distal RTA, infants and young children with Lasix therapy. Probably the commonest cause of medullary nephrocalcinosis is what's called as medullary sponge kidney. And then we also see it in a number of genetic causes, such as Bartter syndrome, Dent disease, Lowe's disease, and primary hyperoxaluria. So when we see this kind of picture in an infant or a child with failure to thrive and hematuria, my primary diagnosis is primary hyperoxaluria, but we have to think about all these other causes also. So how do we treat these patients with hyperoxaluria? Number one is flood them with fluid, flush out all those crystals. Those crystals are getting deposited in the tubules. They're causing mayhem and havoc. Try to flush them out. And this is the guideline we give our patients. 5 years, 1 liter per day. 5 to 10 years, 1.5 liters per day. And above 10 years, 2 liters per day is the minimum fluid intake. We do limit their dietary sodium intake because excessive sodium intake will lead to excessive sodium in the urine, which drags calcium with it and causes increasing calcium oxalate crystals. As I said before, we maintain normal dietary calcium. We avoid excessive animal protein intake, easy for vegetarians, not easy for non-vegetarians. The reason why animal protein is associated with increased kidney stones is because it acidifies the urine and causes more crystal formation. And we normalize vitamin D status because if a patient has excessive vitamin D, that causes increased calcium absorption from the gut and excessive calcium deposition in the kidney. specifically hyperoxaluria, we tell them to stop or decrease dietary oxalate. Yeah, when you tell children to avoid beets and spinach and rhubarb and tea, yeah, they're okay with it. But when I tell them to decrease chocolate, they say, doctor, I'm not going to come and see you anymore. Big problem. We discontinue vitamin C supplements, and we give them all potassium citrate supplements, and that alkalinizes the urine and increases urinary crystal dissolution. And we also use magnesium oxide, which is a very good inhibitor of calcium oxalate precipitation. So the combination of potassium citrate and magnesium oxide helps a lot in these patients to prevent ongoing calcium oxalate deposition. And we always give them a trial of pyridoxine, which is vitamin B6, and we use huge doses, not the usual vitamin B6 dose. We use 20 milligrams per kilo per day. And the reason for that is 20 to 30% of patients with PH1 will respond just to pyridoxine and will stop the progression of kidney failure. We do have to worry about sensory neuropathy in these patients. And I do want to emphasize, how does pyridoxine work, B6, in patients with PH1? Well, it works on the exact enzyme that is deficient in PH1, and pyridoxine increases not only the cytosolic expression, but also the activity of this enzyme and the import of this enzyme into the peroxisome. So this enzyme, AGT, is produced in the cytosol. Pyridoxine will increase its production, its expression, its activity, and its import into the peroxisome, where it needs to act by preventing conversion of glyoxylate to oxalate. So that's how it works. It works in about 30% of the cases. It doesn't work forever, but at least it gives us some time, maybe 2 to 3 years until we get other things that are working. Coming soon, this is a horrible disease. Most of these children and infants progress to systemic oxalosis. They progress to needing dialysis and transplantation. And even after that, they have a lot of problems because of systemic oxalosis. But this is all changing. There are 3 new treatments that are coming. One is Oxalobacter formigenes derived bioactive factors. So Oxalobacter is a common salt. It is present as part of our gut microbiome. And that's why many of us don't get kidney stones, because we have enough Oxalobacter in our gut, which normally binds to oxalate. Now, we now know that there are Oxalobacter-derived factors which we can give orally, which promote oxalate excretion through the gut. And this is a work in progress, and the initial results are quite promising. Then there's RNA interference treatments that are very promising, and here's one. And what they do is they target the hepatic peroxisomal glyoxylate oxidase, that particular enzyme that is mutated in patients with PH1. So what you can do is you can create an RNA inhibitor to that particular enzyme and attach it to GalNAc, which then targets this to the liver and only the liver. So this is a therapy that's now in phase 3 clinical trials. And similarly, there's an interfering targeting using the cytosolic LDH. So you can take the LDH RNA inhibitor, attach it to GalXC, which is another way of targeting this compound to specifically the liver. And phase 2 trials are now successful, and they're moving to phase 3. And the explanation for that liver-specific interference is here. So you can take your RNA inhibitor of choice, whatever you want to inhibit, and you put it in there, and then there's a constant sequence, and there is a sequence called the GalNAc sequence, which then targets this substance only to the kidney. So this is a stable molecule which is selectively taken up by hepatocytes only. And then once it gets into the hepatocyte, it's cleaved, and then your RNA inhibitor of choice is released within the hepatocyte. It is now given as a subcutaneous injection once a month for 3 months, and then once every 3 months. So it's given at home by patients and families, and it is working very well. And these are the 2 drugs that I want to talk to you about today. This is lumasiran, this is nedosiran. Lumasiran is an RNA inhibitor of this enzyme, the oxalate oxidase. And therefore, if you inhibit this, you're going to prevent production of oxalate and you're going to get accumulation of glyoxylate. And that does not have any negative connotations to it. You can have accumulation of glyoxylate in the peroxisome and that does not cause any problems. Similarly, in the cytosol, you can inhibit the LDH enzyme, which is responsible for conversion of glyoxylate to oxalate. Again, the glyoxylate will accumulate in the cytosol, will enter the peroxisome, and that does not have any untoward side effects. So these are the new treatments that are now in phase 3 clinical trials. We think it'll be available in the next 12 months or so. And the beauty, like I said, is just given once every 3 months. Subcutaneous injection can be given by the patient or family at home. So we're hoping that in the next 1 to 2 years, the really bad prognosis associated with the hyperoxalurias is going to change dramatically. But not today. Today, what can we do? Peritoneal dialysis is not sufficient for these patients. Even standard conventional hemodialysis is not sufficient. We have to do intensive hemodialysis, 4 to 5 hours every day, at least 5 days a week, sometimes 6 days a week is absolutely required to decrease the oxalate load into the systemic circulation. And we actually even need to further intensify the dialysis just prior to a transplantation. So if a patient with primary hyperoxaluria is due for a kidney transplant, we sometimes dialyze and do hemodialysis for 12 hours continuously before we put in a new kidney to minimize the oxalate load in the new kidney. So transplantation is really the treatment of choice, and combined liver and kidney transplant is optimal for patients with renal involvement, as long as they're intensively dialyzed. And then liver transplant, of course, is the curative measure and can be a good option by itself in patients with minimal renal involvement. So if we pick up an infant or a young child with primary hyperoxaluria very early, before the kidney is involved, then we can do just a liver transplant, and that is curative. So coming back to our case, he was 17 years old by the time the diagnosis was made, was genetically confirmed. Luckily, at that time, his kidney function was still normal. So it took me 1 year to actually establish the diagnosis because this is an uncommon cause of kidney stones, but we finally did. But he did respond to pyridoxine for 2 years. And so that was very useful because that decreased his urine oxalate levels and he was able to continue with normal kidney function with minimal systemic oxalosis. But then by the age of 19, he started progressing and he got CKD stage 4. We listed him for a combined liver and kidney transplant, and he was lucky enough to get that. He got a combined preemptive liver kidney transplant, deceased donor, and he did great. And then at about 22 years of age, he was transferred to the adult service. And I spoke to them recently. He's still doing pretty well, although he has some chronic kidney disease, which many of our kidney transplant patients. So take-home messages, and this is my last slide. So the incidence of pediatric kidney stones is really high, 1 in 1,000. It is going up very globally, and it's associated with high morbidity, high cost. The biggest problem is that recurrence is common, and kidney stones in kids cause chronic kidney disease. And almost always there's an underlying risk factor that we as pediatric nephrologists should absolutely look for in all children with kidney disease. Look for metabolic causes, look for structural abnormalities and recurrent UTI. Thank you for your attention. I'm happy to answer questions. So there are a number of questions on the group chat. One of them is, do you look at urinary sodium levels? Yes, absolutely. Excessive urine sodium intake, excessive sodium intake and excessive urine sodium is an important cause of calcium-related crystals and stones. And that's because when you have excessive urine sodium, that drags calcium with it and causes kidney stones. And that's one of the important dietary factors of recurrent kidney stones. So all patients with kidney stones, we do put them on a low sodium diet. Next question, in your routine practice, what is the yield from metabolic evaluation? About 50% of children with recurrent kidney stones will have some metabolic abnormality, either excessive calcium or excessive sodium or low levels of citrate, or some of the more rarer causes, like the low levels of magnesium, low levels of potassium. Those are, like I said, inhibitors of kidney stones. And then we get the rarer things such as cystine stones, as well as what we just described, which is hyperoxaluria. How do we differentiate medullary sponge kidney from hyperoxaluria by scan? Great question. No way to differentiate it that I know of. The only way to confirm medullary sponge kidney is by doing an IVP. It shows the classic appearance of medullary sponge kidney. I have not done an IVP in 25 years, so I don't do that test anymore. Some sensitive forms of CT scan are able to differentiate medullary sponge kidney also. So if you are concerned about medullary sponge kidney, the most useful non-invasive test that you can do today is a high sensitivity CT scan. So those are questions in the chat box. Any other questions that I can answer?
Yeah, there is one more question in the chat box. Yeah, presence of few oxalate crystals in urine, is it not common to see them in known stone formers also? And when should we consider it as significant? Here in the case,
yes,
stone was there, and so went ahead with evaluating further. Otherwise, if you find few oxalate crystals in a random evaluation, would you suggest further evaluation?
So if we get few oxalate crystals, first of all, why are you looking for urine oxalate crystals? The patient must have presented to you with some symptoms, right? If the symptoms are suggestive of kidney stones, renal colic, abdominal colic, and that patient has oxalate crystals, then yes, I would image for kidney stones. And if I don't find kidney stones, I'll tell the family, hey, maybe you did pass a kidney stone, you're at high risk. These are the things that you can do: increase your fluid intake, decrease your oxalate intake, decrease your sodium intake. And if you get more symptoms, we can image you again. So that's the usual approach. If the imaging shows kidney stones, then yes, we would definitely do the full metabolic evaluation. So just a few oxalate crystals in the urine. The next thing I would do is I would check the urine calcium, citrate, and oxalate level on a spot urine. And most commonly, we're now finding low citrate levels in these patients. And if we supplement them with oral citrate supplements, the oxalate stones go away. And the reason why that happens is that when you increase the amount of citrate in the kidney, the calcium will preferentially bind to citrate, and the calcium citrate complex is soluble, and we just pee it out, and that's the end of the story. If there's not enough citrate, the calcium is a very promiscuous guy. He will go and bind anybody. And if there's not enough citrate, he will go and bind to oxalate and phosphate. And those crystals are insoluble, and they cause blood in the urine, they cause dysuria, they cause crystals in the urine, and eventually they can stick together and form kidney stones.
There is one more question in the chat box. Are there currently treatments for children with established stones that can replace urologic interventions as opposed to just prevention?
Yeah, again, great question. We involve urology for patients who have obstructing stones, or patients who have recurrent stones with symptoms that we cannot manage medically. We also involve urology in patients with kidney stones who have a complicated urinary tract, such as obstruction, and we involve urology in patients with kidney stones that have a concomitant pyelonephritis or urinary tract infection. And finally, we involve urology in kidney stones in patients who have a single kidney. So patients with either obstruction or with concomitant acute infections, we will have urologists go and take it out. Otherwise, the majority of patients are managed medically. We give them IV fluids, we give them pain medications, and we give them medical expulsion therapy. We give them alpha blockers, such as tamsulosin. And what that does is that it dilates the distal ureter and the ureteropelvic junction, so that if somebody's trying to pass a kidney stone, once we dilate the system, the kidney stone gets passed.
Do you use steroid in such cases in the medical expulsion therapy?
No, we do not use steroids. The medical expulsion therapy is largely tamsulosin. Any cutoff time for diuretic-induced medullary calcium? Yeah, great question. So many infants who are premature, who are given Lasix during their neonatal stay, have nephrocalcinosis and kidney stones. The majority of them will resolve by 1 year of age. And the longest I have had is 4 years of age, but the majority, 80 to 90%, will resolve by 1 year of age. So typically we can stop chlorothiazide or hydrochlorothiazide therapy after 1 year of age. How long should citrate supplements be continued in a recurrent stone former? Nobody knows the answer. I don't have a crystal ball. So what I tell the patients is I'm going to put you on this for 1 to 2 years. And then if you don't have any more kidney stones and if you don't have any crystals in the urine, we'll stop it. And then we'll see you within 1 month. And we will look at the urine. And if the urine shows that the crystals are back, then we put them back on the citrate supplements. I've had patients on citrate supplements for 15 years. It is relatively harmless as long as you take it with food. The potassium citrate supplements can cause GI irritation if taken on an empty stomach. And I actually had one patient who had a perforation of her stomach from taking citrate supplements, but she incidentally developed gastroparesis for an unrelated cause. And they continued to take the citrate supplements, and it all accumulated in the stomach. There wasn't any food there, and that caused tremendous irritation and actual perforation. That was my worst case. But that is very, very rare. As long as you take citrate with food, there are no side effects. How common is lithotripsy done in children? Is there an age cutoff for doing the procedure? Again, great question. Lithotripsy is done in patients who have stones greater than 1 centimeter in size that are embedded in the kidney and are not anywhere near the urinary tract, meaning not near the pelvis, not in the ureter, and are causing pain. So lithotripsy is reserved for patients with symptomatic, painful kidney stones that we don't think are going to pass, either with medical expulsion therapy or with increased fluid intake. We typically do not do lithotripsy in children less than 2 years of age. And the reason for that is lithotripsy will cause a lot of fragmentation of the stones. And then since the urinary tract in infants and young children is still developing, that can cause ongoing damage to the ureter, can cause urethral strictures and things like that. So typically we will reserve lithotripsy for older kids with larger kidney stones, greater than 1 centimeter, which are not passing and are causing painful symptoms. The majority of patients, infants and children, if they have kidney stones that require surgery, we prefer to do endoscopic retrieval. So we pass an endoscope through the ureter through the urethra into the bladder, through the ureters, and use a basket to pull out the kidney stone. Sometimes we'll do laser lithotripsy if the stone is too big. So you can go by endoscope to the kidney stone and do a very targeted lithotripsy using lasers, and that will break up the stones, and then we can pull it out. Is there specific measures to be taken when we initiate dialysis in a child with hyperoxaluria? The specific measure is the fact that conventional dialysis will not work. They need very, very intensive dialysis. They need dialysis 4 to 5 hours every day, perhaps at least 5 days a week, sometimes even 6 days a week. And then if they're nearing a kidney transplant, we do it even more. So a lot more intensive dialysis is the specific measure. And in our experience, and in majority of patients, majority of nephrologists will say peritoneal dialysis is just not efficient enough in patients with primary hyperoxaluria. What's your experience with uric acid stones? So hyperuricosuria can be seen in the rare diseases of purine metabolism, Lesch-Nyhan syndrome and things like that. It can also be seen in some patients after tumor lysis syndrome. And we have seen a few patients with tumor lysis syndrome who have excessive uric acid in the blood and in the urine, and they do form uric acid stones. They are radiolucent, so we cannot see them by X-ray, but we can see them by ultrasound and CT scan. Typically, those patients will respond to either medical expulsion therapy or to fluids. Rarely have we had to use agents like allopurinol to decrease the uric acid load in the kidney. And of course, if there is a primary cause, such as a Lesch-Nyhan syndrome, we have to treat the primary metabolic disease.
Can I ask a question about transplant? Yeah. It's about, see, it's easy to decide upon liver kidney transplant for a child with severe renal disease and hyperoxaluria. But supposing we had a boy who was transplanted at about the age of 14 to 15 years of age for primary hyperoxaluria. His sister also had the same gene and had a history of stones. We did a 24-hour urine test elevated. So we started on pyridoxine, she responded. And she did not develop. We had actually planned for a preemptive liver transplant for her. But over the years, she has had she still continues to have mild uric, if you do a that oxalate creatinine ratio is about just about 0.2 to 0.3 in that range. It's not normal, but it's slightly above normal on pyridoxine and citrate. But we didn't. So the last 5 years we've been following, we didn't do a liver transplant for her. So what would be the approach for this? Because this is a difficult decision to make, whether we should do a liver transplant or not.
I think it's reasonable. So there's two answers to that question. It partly depends on the EGFR, and it partly depends on if you have evidence of systemic oxalosis. Sometimes systemic oxalosis is difficult to determine. We do retina exams, we do echocardiograms, we do skin biopsies, but sometimes the microvascular changes are not apparent. And so we're taking an ongoing risk in these children if we don't do a liver transplant. Having said that, at this point, today, I would not have said this 5 years ago, but today, what I would say is just maximize your medical therapy. Because these RNA inhibitor studies agents are going to be available in the next 1 to 2 years. And so that could be the remarkable treatment. They get an injection once every 3 months at home, and then that controls the problem. So at this point, I wouldn't rush to a liver transplant.
Do you try pyridoxine in hyperoxalurias which are non-primary, which are non-genetic? No, because the way pyridoxine works is by enhancing the activity of that particular enzyme, glyoxylate oxidase. It increases the production of that enzyme, increases the activity of that enzyme, and it increases the translocation from the cytosol to the peroxisome where we want it to work. If it's not primary hyperoxaluria, genetic type, then it's idiopathic, right? So in idiopathic hyperoxaluria, we try all the usual measures, the medical measures that we talk about. I have never given those patients pyridoxine, but I don't see any downside of trying pyridoxine. Some people say pyridoxine works only in PH1 and not in PH2 and PH3. In my own experience, I had one teenager with PH3 who is well controlled with pyridoxine, whose kidney function is normal, gets an occasional kidney stone, and is doing well. So short answer is it's worth a try.
So,
And if you see vitamin D deficiency in a patient with calcium oxalate stones with some hypercalciuria, do you still go ahead and replace the vitamin D?
Yeah, another great question. When you see patients with hypercalciuria and vitamin D deficiency, one thing I want to absolutely make sure is that this patient does not have primary hyperparathyroidism. Because as you well know, patients with hypercalciuria could have primary hyperparathyroidism, and those patients can frequently have vitamin D deficiency as a feedback mechanism. So I would very carefully look at calcium phosphate and PTH levels in those patients.
Thank you.
And then if that's all normal, there is no absolute reason to treat these patients with vitamin D unless they have vitamin D deficiency that is symptomatic. Right?
there is one more question in the chat box, Prasad.
Sure. Had a 6.5 kilo child with hyperoxaluria, so had to dialyze with pediatric hemodialysis filter, which is high flux. Yes, in due course of time, but low serum albumin, and child became very edematous. Anything that can be done about what mode of dialysis should I choose? There are some forms of high flux dialysis that are associated with hypoalbuminemia, low serum albumin. And I don't know the reason why. It's probably because some of the albumin, so it's like a cytokine kind of reaction. It actually binds to the hemodialysis filter itself and depletes the body of albumin. The only thing I can think of is replacing the albumin and removing the extra fluid. Any other ideas from the group about this? I'm sure the adult nephrologists do see this, low albumin levels in high flux hemodialysis. Okay, well, it's being reported more and more in patients with COVID-19 and AKI. So COVID-19 with severe AKI, they get put on high flux dialysis, and for some reason that we don't understand, they get low albumin, they do get edema, and then they go into multi-organ failure. What is the usual dose of pyridoxine? 10 milligrams per kilo per day. We escalated up to a maximum of 20 milligrams per kilo per day, but divided into 2 to 3 doses.
About dialysis, high flux, actually we don't use that much of high flux dialysis. When you use CRRT, generally we don't go more than 3 or 4 days. So by the time either the patient recovers and we are able to put them on hemodialysis, or something, the patient dies. So generally we don't see that. But I'm wondering whether the low albumin is due to the disease process itself and not due to the prolonged disease process itself leading to, so after all, an acute phase reactant.
I don't know the answer to that.
And what is the role of Oxalobacter formigenes? What is your experience with that, Prasad? Actually, we have got that formulation here.
So it's still under clinical trials. It's gone to phase 3 clinical trial. Phase 1 and phase 2 were very encouraging. It was done in patients with pH 1, 2, and 3, including children down to 6 years of age. We haven't tested it in below 6 years, but up to 6 years of age, what has been shown is that it decreases urine oxalate levels to the upper limit of normal. So very promising, and no side effects. That's the beauty of it.
How much is the dose that is used? Is there any definite dosing guidelines that are there in children?
Yes. So yes, the clinical trials have, I don't know off the top of my head what the dose is, but the clinical trials have a very specific dosing, So the initial trial was to just use Oxalobacter, the bacterium itself. And that did not work. That clinical trial was closed down because of lack of efficacy. But now they've taken the bioactive factors from Oxalobacter fumiginese, and they've created a cocktail of these factors. And that seems to be working very, very well. So I think in the next 6 to 12 months, we will have better guidance as to what treatment based on the age groups and things like that.
And we in our clinical practice come across a lot of small babies, 3 months to 5 months of age, who present in ESRD, and they will be having kidney that is rock, like totally calcified. And such kids usually, once we start the dialysis, what we come across is over the years, they have a lot of vascular disease, retinal disease and all. And will all the new coming up are of benefit in such kids to reduce the extra renal manifestations of oxalate? Will these molecules help in having the kidney back on the track, or the kidney that is gone forever?
I think the damage is done. The damage is done. Similarly, the oxalate deposition in the eyes, in the heart, and in other vital organs, that damage is done. Now, the kidney, being the most wonderful organ in the body, does have a remarkable ability to recover, regenerate. So if we stop that oxalate deposition in the kidney, there is a good possibility that there's at least some regeneration of the kidney. But if a patient is on dialysis, are they going to come off of dialysis? I don't know. One of the arms of this study, the phase 3 study, is looking at those RNA inhibitors in patients who are already on dialysis. So we will have the answer to that in the next 1 year. Okay, the other question is, your thought on post-liver transplant for hyperoxaluria was on CRRT for 3 days and reinitiated CAPD. So once the new liver is in there and the new enzyme is in there, we do tend to continue aggressive hemodialysis for at least 1 to 2 days, because we want to make sure that there's no remaining oxalate from the previous bad liver that has been deposited in other organs, maybe the spleen, maybe other organs that can still be leached out. So typically a lot of intensivists after liver transplant for hyperoxaluria, even if the kidney function is adequate, they will continue the dialysis, not for kidney support, but for ongoing oxalate removal.
I think the question was on post-liver transplant alone, I think, isn't it? That was, was it what they meant? I'm not sure. On
Yeah,
liver
so
transplant alone.
If the liver transplant was done on a patient who had completely normal kidneys, then I don't see the reason to do dialysis on them post-liver transplant, unless you have some evidence of oxalate accumulation somewhere in the body.
If there are
patients,
Satish,
we did sequential liver kidney transplant. Small child, not adequately dialyzed, so we did a liver transplant. Father gave the liver, and then 6 months down the line, same father donated his kidney also, and she had a liver kidney transplant, and she did well. She's now 1 year post transplant. She's fine otherwise.
So the largest series that came out of the Mayo Clinic compared sequential liver kidney transplant to concomitant liver kidney transplant. And they showed that the patients who had combined liver kidney transplant at the same time tended to do better overall. The outcome was better. But the caveat there is that the sequential liver kidney transplant patients were done about 10 years ago. And then now they've moved all their patients to combined liver kidney transplant. So there are many factors that could be responsible for the better outcomes of the combined. But yeah, most of the time we try to shoot for the combined. Of course, it partly depends on organ availability. So if we get a liver, yes, we will put it in, and then we'll take care of the kidney later. Yes, I think that last question on the chat box is similar to what Dr. Satish asked.
So if no more questions are there, I would like to invite Dr. Satish Balan to thank Dr. Prasad and Mark and conclude the session.
I think we had a very wonderful discussion today. It was a very fruitful engagement for the last 1.5 hours or so. I think 1 hour 45 minutes actually. And Dr. Mark talking about neonatal hypertension. It's a completely new field for at least adult nephrologists like us, but it's extremely interesting to hear about it. And I wasn't even aware that neonates should have hypertension. So it's a very nice to hear, and eye-opening for most of us. And of course, discussion on stones is a never-ending discussion with so much of material on that, and as well as the questions asked, and also it was really a roller coaster of a discussion that we had. And I think it was very interesting and as well as enlightening and educational for all of us. I think we should have more such meetings. Hopefully in two months down the line, we'll have another meeting as good as this or even better. So thank you, Dr. Mark. Thank you, Dr. Prasad. And thanks to everyone who came here and listened to this meeting.
Yeah, thank you, everybody. Throw out your plastic containers.
Okay.
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 So we'll close the meeting.
Yeah, bye.
Bye.